Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 438 of our pharmacotherapy series, which majors in breast cancer. STR has a long progression-free survival on hormonal therapy. Over the course of 4 years, she progresses on sequential anastrozole, then fulvestrant, then exemestane plus everolimus, and eventually, megestrol acetate. Each time she has progressed, the progression-free interval has shortened. Follow-up staging tests now reveal new liver lesions measuring 1 cm by 1 cm and 2 cm by 1 cm. A CT scan of the chest was negative. She is not currently experiencing any symptoms of her disease. So my question to you reads: what should the treatment course include now that STR has progressed after numerous lines of endocrine therapy? Because STR has progressed through multiple lines of hormonal therapy and the progression-free interval has shortened with each treatment course, chemotherapy would now likely be the best option. Patients with a good performance status, little previous treatment, prolonged progression-free intervals, and limited metastatic disease are more likely to respond to further treatment with chemotherapy. Chemotherapy is continued as long as the person is receiving benefit and is tolerating toxicities associated with treatment. If the disease progresses or the toxicities become intolerable, therapy should be changed or stopped. Patients experiencing toxicities may be placed on a chemotherapy holiday until toxicities are resolved or until therapy is tolerable. In the metastatic setting, stabilization of disease and palliation of symptoms are considered when deciding what chemotherapy regimen to use. Sequential, that is single agent, versus combination chemotherapy should be discussed. Combination chemotherapy is generally associated with more toxicities than sequential treatment. However, it provides improved response rates. Patients with substantial symptoms from their disease may initially be given combination therapy to rapidly shrink the tumor. Combination therapies that have demonstrated improvements in survival are docetaxel and carfacetarbine, paclitaxel and gemcitabine, and doxorubicin and paclitaxel. Based on STR's lack of symptoms, sequential therapy would be the best option for her at this time. This would offer her less toxicity and reserve other chemotherapeutic agents for the future. Chemotherapy decisions can be very complex. There is no one standard regimen, and decisions should be made on an individual basis based on the patient's prior treatment, concurrent comorbidities, and time from adjuvant therapy to metastatic disease. Most individuals today will have received anthracycline and taxane chemotherapy in the adjuvant setting. If the patient's disease recurs quickly after adjuvant therapy, i.e., less than 1 year, the disease is considered resistant to that treatment and different agents should be selected. If a patient receives adjuvant paclitaxel and progresses on therapy, there are data to support the use of docetaxel in the treatment of metastatic disease because of the lack of cross-resistance between taxanes. Other chemotherapeutic agents with mechanisms similar to taxanes, such as eribulin or ixabepilon, have been approved for use in previous taxane failures. These agents offer additional options to patients who had responded to previous therapies. Previous toxicity is also considered when selecting therapy. In patients with pre-existing neuropathies either from diabetes mellitus or previous chemotherapy, taxanes may not be an appropriate choice because these agents can also cause neuropathy. Additionally, carpacetarbine may be chosen over intravenous chemotherapy because this agent is administered orally. Clinical trials are always an option for patients if they have a good performance status. Many clinical trials are available and should be discussed with the patient if clinical trials are a possibility. Because STR has received an anthracycline and taxane agent in the adjuvant setting, an agent such as carpacetarbine would be an appropriate choice. This is an oral agent and also has the indication for first-line treatment of metastatic disease after failure of anthracycline and taxane chemotherapy. My next question to you reads: would STR be a candidate for any biologic therapy for the treatment of her metastatic breast cancer if she was HER2 positive? Trastuzumab revolutionized the treatment of HER2-positive breast cancer. Newer biologic therapies are also available for use in the metastatic setting. Trastuzumab is a fully humanized monoclonal antibody that binds to the extracellular HER2 receptor and works via antigen-dependent cellular cytotoxicity. When chemotherapy alone was compared with chemotherapy plus trastuzumab in HER2-positive metastatic breast cancer, the addition of trastuzumab therapy significantly increased survival. This was the first study of its kind using biologic therapy and demonstrating survival benefit in metastatic breast cancer. Current practice is to continue the trastuzumab in patients who progress on a chemotherapy regimen, but switch to an alternative chemotherapy agent. As with all chemotherapeutic agents, breast cancer can become resistant to therapy. Trastuzumab provided significant improvement in overall survival for patients with HER2-positive disease. However, trastuzumab resistance occurs. Newer pathways and resistance patterns have been identified to help clinicians understand the complexity of this disease. 2 therapies are now approved for use in HER2-positive patients. Pertuzumab offers a novel mechanism of action for HER2-positive patients. This agent is a monoclonal antibody similar to trastuzumab but blocks the extracellular domain on the HER2 receptor and blocks ligand-dependent heterodimerization with HER1, HER3, and HER4. The binding is different from trastuzumab in that trastuzumab binds to domain 4 while pertuzumab binds to domain 2 of the HER2 receptor. The Cleopatra trial evaluated pertuzumab in combination with docetaxel and trastuzumab versus docetaxel and trastuzumab and placebo for the first-line treatment of metastatic breast cancer. At a median follow-up of 50 months, The pertuzumab arm demonstrated improved OS of 56.5 months versus 40.8 months in the docetaxel plus trastuzumab arm, hazard ratio of 0.68, with a 95% confidence interval of 0.56 to 0.84 with a p-value less than 0.001. Those treated with pertuzumab experienced more diarrhea, rash, mucosal inflammation, and febrile neutropenia. Pertuzumab is approved for use in the first-line metastatic setting and the neoadjuvant setting in combination with docetaxel and trastuzumab. Because pertuzumab does target the HER2 receptor, there is a concern regarding cardiac toxicity associated with its use. In the cardiac assessment of the Cleopatra trial, the incidence of cardiac adverse events, all grades, was similar between arms, 16.4% versus 14.5% in the placebo arm and the pertuzumab arm, respectively. Most patients experienced asymptomatic decreases in left ventricular ejection fraction which resolved upon removal of the drug. Trastuzumab emtansine, also known as TDM1, is a unique formulation of an antibody-drug conjugate, trastuzumab linked to DM1, a maytansine derivative. Maytansine is a potent microtubular inhibitor. Once the drug binds to the HER2 receptor, it is internalized and then undergoes degradation, releasing the cytotoxic agent to induce apoptosis. This agent was approved based on the results from the Amelia trial comparing trastuzumab to capecitabine and lapatinib in patients who had failed previous taxanes and trastuzumab. Trastuzumab improved both PFS and OS. Common toxicities for this agent include peripheral neuropathy, fatigue, anemia, increased liver enzymes, and myelosuppression. As with other HER2-targeted therapies, the concern for cardiac toxicity was evaluated. Less cardiotoxicity was identified in the trastuzumab group compared to the combination arm, 1.8% versus 3.3%, respectively. This drug's name is very similar to traditional trastuzumab and hence the FDA recommendation for the addition of the prefix adu to the name. The approved indication of this agent includes use in patients with HER2-positive metastatic breast cancer who have previously received trastuzumab and a taxane, separately or in combination. Lapatinib was the second HER2 target agent approved after trastuzumab. It is an oral tyrosine kinase inhibitor, a small molecule that inhibits both the activity of HER2 and the epidermal growth factor receptor. Lapatinib received approval based on a study in which carpacetarbine was compared with carpacetarbine plus lapatinib. This trial included patients whose disease had progressed during or after an anthracycline, taxane, and trastuzumab therapy. Time to progression was statistically significantly better with the combination therapy compared to carpacetarbine alone. Hazard ratio 0.46 with a 95% confidence interval of 0.34 to 0.71 with a p-value less than 0.001. Toxicities commonly associated with lapatinib are diarrhea and rash. Concerns of cardiotoxicity associated with lapatinib have been closely monitored in these trials. Because one of the mechanisms of lapatinib is blockade of HER2, like trastuzumab, there is concern regarding its cardiotoxicity potential. Currently, data do not demonstrate an increased risk of cardiac dysfunction with lapatinib. However, long-term data are needed. Lapatinib's approved indications include use in combination with carpacetarbine or combined with letrozole therapy, or in those who have failed prior anthracyclines, taxanes, and trastuzumab for metastatic breast cancer. One concern with lapatinib is its inhibition of the cytochrome P450, CYP, 3A4 and 2C8 isoenzymes. Because of this, when a patient is initiated on therapy, a full review of medications should occur to ensure no drug-drug interactions. Recommendations are included in the package insert for use and dosing of lapatinib with CYP3A4 inhibitors and inducers. If TR had HER2 positive disease, a common first-line regimen to use in the metastatic setting would be pertuzumab, trastuzumab, in combination with docetaxel based from the data of the Cleopatra trial. Second-line therapy in those that are exposed to previous trastuzumab therapy could include trastuzumab emtansine or lapatinib in combination with carpacetarbine therapy. Other unique targeted therapies are being evaluated in metastatic breast cancer. Poly-ADP ribose polymerase, abbreviated as PARP, inhibitors potentially offer unique activity for patients with triple-negative breast cancers, that is ER, PR, HER2 negative disease. These tumors are typically refractory to chemotherapy and difficult to treat. PARP is an enzyme that repairs DNA breaks and is overexpressed in triple-negative breast cancers. Hence, this class of investigational inhibitors is expected to enhance the activity for cytotoxic therapies such as DNA-damaging agents. Initial studies have been promising, and currently Phase 3 trials are underway to evaluate the anti-tumor activity of PARP inhibitors in the metastatic setting. Other agents in the pipeline are mTOR, an abbreviation for mammalian target of rapamycin inhibitors, HSP90, an abbreviation for heat shock protein 90 inhibitors, multi-targeted inhibitors of vascular endothelial growth factor receptor, and platelet-derived growth factor, as well as other monoclonal antibodies. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 439.